Good day, dear colleagues. Today, I'm looking forward to having this conversation on post-traumatic stress disorder with a deep focus on two things. Number one, I want to talk more about a deeper understanding of the neurobiology of this condition. And my goodness, we know so much more than we did perhaps even 5 years ago. Secondly, I'm going to leverage this emerging neurobiology to see where drug development for the treatment of post-traumatic stress disorder is going. It's enormously exciting, and I cannot wait to tell you more about it. My name is Rakesh Jain, and I am a clinical professor of psychiatry at the Texas Tech University School of Medicine in Permian Basin. Let's go on a quick tour, shall we? So what causes post-traumatic stress disorder? And quite interestingly, of course, traumatic stress has to kick it off by definition, but I do want to alert you there are two kinds of traumas we clinicians now see. One of them tends to be a single large event like mass violence, such as a issue of terrorism or massacre like mass shootings or war, ethnic cleansing, assaultive violence, so military combat, working in the fire department. It can also be a single very significant event such as rape or physical assault. But other traumas should not be forgotten. So for example, serious accidents or persistent physical or emotional abuse in the context of a relationship. There are many, many, many reasons why post-traumatic stress disorder can be caused in an individual. The second question is, what are some of the risk factors for PTSD? We know quite a bit about that as well. There are individual level characteristics such as being female increases the risk. Certain genetics, certain methylation patterns in the genes can increase the risk. Early life stressor, my goodness, that is a tremendous red flag for the development of post-traumatic stress disorder, as is perhaps the presence of psychiatric comorbidities. It's a lot of challenges, but the stressor characteristics tend to be of the following nature. The stress tends to be uncontrollable, inescapable, unpredictable, repeated, and severe life-threatening. Millions of people sadly suffer from this condition. We should put these risk factors and traumatic stress to better understand chronic stress pathology, PTSD being just one of them. So these two come together. Risk factors and traumatic stress come together in a single individual to create chronic stress pathology. I will tell you much more about that in just a minute or two. But be aware, it's not just the presence of trauma or just the presence of risk factors. It's a confluence of these two issues merging to create what you and I would clinically call post-traumatic stress disorder. I think we should examine the circuit of post-traumatic stress disorder. So why don't we start at the top and then we will go to the right and then complete our loop. There are two new concepts I would love for you to wrap your head around. That being monoamine-based pathology and then amino acid-based pathology. They are different. They can cross over, but what they lead to is either what's called synaptic gain, which means the nucleus accumbens, for example, fires way too much, or it can lead to synaptic loss, which is quite different, which is the inability of the inhibitory parts of the brain, primarily the prefrontal cortex, from functioning. So quite different pathologies. We'll be talking more about that because therein may lie the opportunity to help our patients. All of this leads to synaptic disconnectivity, which leads to fear and emotion dysregulation, and then that presents as the full symptoms of post-traumatic stress disorder, along with its troublesome comorbidities of depression and anxiety. So PTSD does not appear to be just a boom, an event happened and something broke. This particular pathology, which we'll be diving into in a minute, is in fact quite important to understand. So let's dive into it. Two different pathologies. Pathology one is monoamine-based pathology. It actually appears norepinephrine may be the primary challenge here. What that does, two things. Too much norepinephrine, uncontrolled norepinephrine, does increase hypervigilance, which does lead to dopamine burst firing alterations. So we end up having an individual who's hyper alert. But the problem is they can't truly escape the environment. And as a result of this hyperarousal, have a lot of symptoms and a great deal of suffering. Now, look at this completely different model, which is an amino acid-based pathology. This one is primarily glutamatergic, primarily GABAergic. Here we see neuroinflammation. Here we see HPA dysregulation. Here we see the inability of the prefrontal cortex to exert a dampening effect on something like the nucleus accumbens. When that happens, you end up having the full symptoms of PTSD. So perhaps the take-home message of this particular slide is to appreciate PTSD can happen for two very different reasons. One would be excess, uncontrolled norepinephrine functionality, but the other could also be the overreactivity of the amygdala primarily, and also an inability of the prefrontal cortex, the top part of the brain, to kind of produce a dampening effect. So monoamine-based pathology, amino acid-based pathology, two different things, but they can confluence together to create lots of challenges for our patients. All of this to say is that the network, well, why don't I show it to you? But the network functioning of the human brain is in fact quite impaired in PTSD. So we all have what's called the salience network, the central executive network, the default mode network. You and I cross over from one to the other seamlessly and appropriately. But when people develop the symptoms of PTSD or stress intolerance like I was talking about, their salience network is overactivated. They detect way too much threat. Their amygdala in particular is overreactive. Well, typically what would happen is the central executive network would dampen it. But the top-down regulation is significantly weakened in PTSD. So what this leads to is network disconnectivity. On top of that, a person can get stuck in default mode network, so a lot of ruminative thought, and excess presence of salience network, so over-vigilance. So this emerging brain network hypothesis really goes a long way to help us understand what actually does happen in the body and the brain of the person who has PTSD. I do want to draw your attention to one organ in the human brain, that being the amygdala, because it is at the center of PTSD. It certainly is. It's a subcortical structure, and I will show you as I am right here. It may be subcortical, but it is like the Grand Central Station in New York City. It is deeply connected to the thinking part of the brain, the emotional part of the brain. It's deeply connected, therefore, to the anterior cingulate or the mediolateral prefrontal cortex. It's also very connected to the neuroimmune system. It's also very connected to the neuroinflammatory system. So amygdala overactivation really and genuinely appears to be at the center of the pathology of PTSD. In fact, it is thought to be one of the most overactive organs in someone with symptoms of PTSD. And here's a wonderful study from Kerry Ressler and colleagues who showed that individuals, even in a safe laboratory setting, when they are exposed to pictures and sounds, and sometimes even thoughts of their trauma, their amygdala reactivity is distinctly different and excessive, which therefore reminds us that the two different pathologies we talked about earlier probably are both at play in an individual with PTSD. So, we should appreciate the role of amygdala, and by the way, not forget the hippocampus and prefrontal cortex at the end of the day modulate amygdala. Therefore, psychotherapies are important. Therefore, treatment of conditions like depression is important. But at the end of the day, if the amygdala is misbehaving, one sadly can expect lots of brain regions, as I'm showing you here, to be abnormal, and that would result in a host of symptoms that are problematic, such as an increased startle response, arousal, vigilance, blood pressure changes, body changes, sleep difficulties, nightmares. All of those are explainable because of amygdala reactivity. Now, psychotherapy is always at the center of the treatment of PTSD. It is always first-line therapy, always. Why is that, though? It's because the prefrontal cortex, when it is strengthened, can in fact dampen the tone of the amygdala, thereby leading to improvement in symptoms. But what if psychotherapy isn't enough? And often it is not enough. Thence, pharmacotherapy is appropriate. So what do we know about the pharmacotherapy of this condition? It's a very common condition, so you would have thought the FDA has a number of different options available, right? Not so. Only two agents, paroxetine and sertraline, are in fact approved for the treatment of PTSD. We do use a lot of other medications off-label, mirtazapine, sometimes even monoamine oxidase inhibitors. We sometimes use antipsychotics. You can see what the therapeutic goal is on the right side. We sometimes even use off-label prazosin, an alpha-1 adrenal receptor antagonist. The problem is it primarily seems to have an effect just on sleep, and it's kind of erratic in other symptoms of PTSD. We often use benzodiazepines in this condition, don't we? Come on, let's be honest with each other. Problem is, no evidence of efficacy and possibly worsening of symptomatology. So there has been a real race to come up with better treatment options for this common and grossly disabling condition. So what do we have? Well, let's look at that. So the future of post-traumatic stress disorder pharmacotherapy is actually improving because we now have a better understanding of the pathology of the condition. So the first treatment that I think we should talk about that's emerging, it's Brexpipersol, which is branded in America as Rexulti. Why is this interesting? I thought it's an atypical. Well, it is, but it's a rather unusual atypical in that it has profound activity on norepinephrine receptors, both presynaptic as well as postsynaptic. It has effects on both the alpha-1 family as well as the alpha-2 family, thereby not increasing or decreasing norepinephrine, but in fact modulating it in a manner that hopefully eradicates the symptoms of post-traumatic stress disorder without harming other things that norepinephrine is involved in: cognition, motivation, drive, mood, etc. Stay tuned, because Brexpipersol database on post-traumatic disorder is both exciting and more data is emerging. I can't wait to see more information on it. And there's further data to be talked about, further interventions. So there's a class of medications called TRPC, TRPC, 4-5, and PTSD. So let's look at the role of TRPC4-5 drugs. So what are they? So TRPC4 and TRPC5, these are channels. These are ionic channels that are involved in the functioning of amygdala. And by the way, amygdala is where fear-related behavior against aversive stimuli lives. So if you think of your patients, that's exactly the challenge they have. So there is a particular drug. It's called BI 1358894. That's a mouthful. This drug comes to us from Boehringer Ingelheim. It's actually been tested in a large number of phase 1 clinical trials, and it looks like it might be a very promising agent in post-traumatic stress disorder. And it's a very novel mechanism. It doesn't appear to treat, if you will, the entire brain as much as it is trying to target the overreactivity of the amygdala, which, if you think about it, appears to be at the core. It's one of the two central foundational cores of the disorder of PTSD. This too, the data is emerging, and I would urge you and recommend to you to stay tuned to what happens. One more time, I want to remind you, psychotherapy is always central to the treatment of PTSD. So even though we're talking about pharmacotherapy, we're not saying that psychotherapy isn't important. In fact, we're saying to the contrary, it's incredibly important. However, when it is inadequate, I'm talking about psychotherapy, pharmacotherapy, if it's well thought out, if it's picked correctly, we can do some really good things by our patients. And in conclusion, I would like to remind you, this is an extremely worthy adversary. Look at some of these key points. It's disabling. Millions of people have it. 6 to 8% of the population. Are you kidding me? That's huge numbers. Think of the suffering. We now have a good idea about the neural circuitry that underlies the disorder. Remember, there is a monoamine and amino acid pathology that is emerging in PTSD. They are different, which only means there's more targets, more opportunities for us to help our patients. Psychotherapy and pharmacotherapy are important because this molecular genetic challenge that these individuals have really does require big and broad thinking from you and I as clinicians. The one thing we cannot do is forget about the plight of our patients with PTSD. As a result, I really do want to thank you for giving me this opportunity to talk with you about post-traumatic stress disorder. Over time, as data and information emerges, I'll post more information for your review. Thanks very much.